I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Good morning, Sally. Nice to see you again.
Yeah, morning. Here we are, another beautiful sunny day in the middle of summer. It's kind of weird, isn't it? It's not supposed to be like this in the UK, but I'm kind of loving it.
It is wonderful. And for those of you who are in the UK listening to this, you won't be surprised that we're talking about the weather. But to those of you who are abroad, we're offering cultural learnings for British people as well. We love to start any conversation essentially by talking about the weather. So we have done that today. But it is indeed a beautiful, lovely day. We're continuing the arc of the story, Sally, aren't we?
We are. Today we're going to launch into transplants, and there's quite a lot to talk about here, but it's going to come in bursts, isn't it, Jam? We're going to have a go, and then a transplant nurse, perhaps the next podcast, and then a patient story. So there's going to be layers of information coming through about this really important part of the pathway.
Absolutely. So last podcast was all about how we get the stem cells, what they are, how we move them out of the bone marrow, and how we collect them and freeze them so they're ready to do what they need to do. So today we're going to talk about the autologous stem cell transplant. Even the way it's described is confusing. What does it mean? What is an autologous stem cell transplant?
So the way I describe it, it's a way of enabling us to give really strong chemotherapy to hopefully calm down the myeloma further. So you have your treatment to begin with, which lowers the myeloma levels in your body or your paraprotein, however you're choosing to measure it. And then the transplant process gets rid of even more of the myeloma. So if there's paraprotein detectable, it might bring it down further. If there's no paraprotein detectable, it may still have benefit in removing any residual myeloma within the body. And the transplant part of it, as we said in our last podcast, refers to the fact that cells leave your body before you have the transplant and they go back into your body during the transplant process. But basically, the therapeutic component of this process is the chemotherapy that it allows us to give.
So it's not like a kidney transplant or a liver transplant where you're physically putting an organ in. The transplant is returning those stem cells, those autologous stem cells that are frozen, back into the body. And just to remind everyone, autologous means that they are from yourself. So there are other hematological conditions where we do autologous stem cell transplants, and the concept is exactly the same. It allows you to give very powerful chemotherapy that not only hopefully gets rid of as much of the residual or leftover cancer, that is, myeloma is of course the one we are interested in, but then as a side effect of that powerful chemotherapy, it wipes out all your bone marrow stem cells. So luckily, of course, we have frozen those autologous stem cells. They are defrosted and they are attached like a blood transfusion. And very cleverly, they know how to get back to where they're supposed to be, which is inside the bone marrow.
Yeah, absolutely. It's a very nifty technique, isn't it? And it's been established, I think, transplants in myeloma therapy for a number of decades now, actually. And it's really been the backbone of so much of what we do. And this is a generic term, the transplant term, to refer to lots of processes that can exist in many conditions. But in myeloma, this is not an operation. You are not getting any treatment from any other person. And therefore, actually, the side effects that you might experience during the transplant tend to relate actually to the chemotherapy that we give rather than the transplant itself. So that's a really important thing to say. And also, when you get a transplant of something else from someone else, let's say a kidney, for example, you often need additional drugs to calm down the body, to stop the body from rejecting that organ or whatever it is you've received. But that's not necessary here, because all you're doing is replacing cells which were originally once yours anyway. So it's much more perhaps straightforward and therefore, as a consequence, maybe less risky, although risk do exist within this procedure, which we'll come on to.
So broadly speaking, we consider autologous stem cell transplant in people up to around the age of 70. But as we've discussed in previous pods, that is not an absolute number. Biological fitness is crucial. Part of what we do after the stem cells have been collected and frozen to when we actually do the stem cell transplant is confirming and establishing that people are fit to proceed with the transplant.
During this period of time, what's really important is once you know you've got your stem cells sort of stored, so they're frozen in that freezer in your hospital or wherever that might be, you need to then make sure that it's still the right thing to do to proceed with the transplant. And by that I mean that your myeloma is still under control. Occasionally we do transplants when the myeloma isn't quite where we want it to be, but more often than not, we want it to be in a good remission to make the most of the transplant, and also to make sure that your body can withstand this process. Because even though you're not on lots of immunosuppressive drugs, for example, and the toxicity might come from the chemotherapy, it still can be very toxic. And one of the ways it's toxic can involve infections. And to fight an infection, it really helps that your heart is working well, that your lungs are working well, that your kidneys are nice and strong. And so in that period between the stem cell collection and the transplant, we screen those organs of your body to make sure that they are doing what they might need to do. So you might have a scan on your heart called an echocardiogram. It's like a jelly scan, the scans you might have done in pregnancy. You might have some breathing tests done just to check that the air flows nicely and the oxygen in and out of your lungs. And also your kidney function may be scrutinised in more detail, particularly if that's a bit borderline. And then once all those tests are done, then the date, or perhaps alongside actually, the date is booked to actually come in for transplant. And that period between the stem cell collection and remission can be variable. I think we sort of said around 4 to 6 weeks, maybe a bit longer than that. It can actually, if you're fortunate, be as short as 2 weeks. So it's highly dependent upon local pressures. But essentially, once you've had those screening tests done on your organs, you're then deemed fit to go forward with your transplant.
So once that is all done, you would see a myeloma doctor in the clinic and you would consent for the transplant, and you will be informed of the potential side effects, the risks, significant risks, things that will happen during the time that you're an inpatient, which broadly speaking is around 3 to 4 weeks, and how you'll feel when you recover. Now, local practices do vary in different parts of the world, and certainly in some parts of the world, the first few days, maybe even the first week, may actually be not done as an inpatient, and you may be close to the hospital in what we call an ambulatory setting, where you are assessed day to day. And in other places, you may be admitted from essentially the day in which the process starts. So if we just go now from the beginning of the transplant. Now, the key thing is, as you mentioned, Sally, this chemotherapy, this dose of chemotherapy, which essentially is there to further put the myeloma into remission. Now, a number of combinations or different sorts of drugs have been used over the years, but the key drug that has actually been there since the beginning is a drug called melphalan. Melphalan is an old type of chemotherapy. It's called an alkylating agent. And this is a drug that's used at a very high dose, as I said, to try and mop up any myeloma that is left in the body. And it's given as a single dose the day before you have the stem cells given back.
So melphalan is one of those old-fashioned drugs. And for some of our listeners, you may have already been exposed to it outside a transplant, actually. We used to give it in tablet form at a far lower dose to older people living with myeloma. But we know it has this really good effect on the myeloma cells, killing them very effectively. But unfortunately, it also wipes out all the other cells. And that speaks to the fact it is one of those old-fashioned drugs that essentially use a sledgehammer to crack a nut, so to speak. And to get rid of the myeloma, like I say, it clears out the rest of the bone marrow.
So this drug is given as a single intravenous dose prior to it being given. It takes about 30 minutes to give. You get anti-sickness medication, you get fluids. And now for something that you probably did not expect us to be talking about, whilst the melphalan is going in, you will be given a variety of lollies to suck. Ice lollies, this is. And this isn't just me going on about one of my ice cream things.
Yeah, I've got to say though, Jam, I don't think every hospital is blessed with an excess of ice lollies, to be honest with you.
Well, I'm going to go round and hand them out. I'm going to be the lolly myeloma man. I mean, the amount we get through in this house with the kids, honestly, I mean, I might not have any left. This kind of reveals an important point, though.
Yeah, no, it's kind of like back to the weather again. Hey, Jam, everything circles back to the weather. you take them and you use them to cool the mouth while the treatment's going in. And rather similarly, actually, just to go off on a tiny bit of a tangent, some of our listeners may be familiar with people having sort of caps to cool their hair down when they're receiving treatment. That's perhaps quite common during some treatments for breast cancer, for example. And the idea is if you can chill the cells, which are in that case responsible for the hair, it might stop those cells from being damaged. And similarly, the same applies when you're having these lollies. They sort of chill the mouth down, and that may confer some protection from the damage of the melphalan and how it can impact on the lining of the gut, but particularly the mouth. Because one of the side effects of melphalan is a condition we describe as mucositis, which is inflammation of the lining of the mouth and through down to tummy and all the way through the gut. But particularly if you get that in the mouth, it can be exquisitely uncomfortable. Some people at its worst, they can struggle to swallow even their own saliva. Now, that's not everybody, but it can happen in a few. And so having these lollies when the treatment's going in may minimise that effect to some extent. That's why they're given in some centres.
And in other places, you may be asked to suck ice or just keep something very cold in your mouth. But you're right, Sally, it's like those coolant masks that we talked about for belantamab. There may be some use of cooling tissues to minimise side effects. But essentially, melphalan, this alkylating agent, it's a very old sort of chemotherapy, and old sorts of chemotherapy are very good at killing rapidly dividing cells. Now, the lining of our gut, and what I mean by that is everything from our mouth right down to our bum, so all the bowels that we have inside, the lining of that is very rapidly growing. And what melphalan does is that it quickly kills that top layer, and that leads to mucositis. And this really does lead into some of the main side effects of the transplant, which are bowel-related side effects. So unfortunately, you can get nausea, abdominal pain. Diarrhea is very, very common. And these sorts of mucositis side effects tend to come on 4 to 5 days after you've been given the melphalan, but it's slightly different in everyone. And broadly speaking, they can last around a week. But certainly cooling the mouth, which is really the only bit of the gut we can simply cool, does very much minimize the mucositis in the mouth, which means that often people can swallow or manage something orally for the entirety of their transplant. But it's different in everyone. But the melphalan is the first thing that happens with the transplant.
Well, after the transplant, so as you mentioned, maybe the day after or sometimes the day after that, the cells are returned to the body and they're infused. The bag is defrosted. It's often defrosted actually in the same room as a patient. There's a special bath the frozen cells can sit in. This warm bath, and then they're infused into the body, hopefully at sort of body temperature. And then they have a chance to make their way back to the bone marrow, hone to the bone marrow, and then they can start the period of essentially repopulating that bone marrow. So the melphalan's done what it needs to do, and the stem cells then do what they need to do, which is help the body heal. Now, that stem cell reinfusion, in and itself, that's actually not really toxic at all. People cope with that really well. Although there is one slightly peculiar side effect, which is also food-related, Jam, isn't it? I wonder if you could share that with our listeners and see if this might ring a bell with a few of them.
Back with the food analogy. So it's very noticeable if someone has had stem cells reinfused, because you will go into their room and you can smell sweetcorn. And it's very unusual, but it definitively smells like sweetcorn, and that's because the stem cells are kept in special fluids to keep them fresh and viable, and one of these liquids smells like sweetcorn, and the smell can last for a good couple of days. And I think initially the patient smells it, but then, like all these things, you get used to it. It's very characteristic, but as you say, Sally, the cells going in essentially is usually a non-event. And we should talk a little bit about the terminology. That's called day zero. So the day you have your cells back is called day zero. You have your melphalan on day, what we call -1. So for most people, it's -1, then 0, 2 consecutive days. For a number of reasons, often it's because their kidneys don't work very well. You might have a rest day in between. But for most people, melphalan the day before and then stem cells on day 0.
Everyone's different, of course, because everybody is different in myeloma. For most people, that period is relatively uninteresting. Not a lot happens. It's pretty boring. I think if a patient does experience the side effects of nausea and vomiting, particularly with the melphalan when that's gone in, there may unfortunately be a hangover, and that may persist for those days after the cells have gone in as well. Completely unrelated to the cells, more related to the melphalan, that hopefully the team looking after that patient will have treated that as best they can with anti-sickness drugs, for example. But actually at that beginning period, really not much happens. That speaks to the point you made earlier, Jam, in that some centres, actually this beginning period can all be done as an outpatient because it's really not terribly exciting. But it's after the sort of like day 3, 4 perhaps of the cells having gone back in that things might change, and that if there is going to be mischief and trouble, that's when it could begin to start.
Diarrhea can be problematic, and understandably, it can make you feel really grotty. It can be that you have multiple episodes with small volumes coming out, or unfortunately, even it can be much more profuse. Now, it's normally the effect of a chemo and not an infection. And it's really important that when it starts to happen, that you get a sample, you send it to the lab, and then you rule out infection, because then we have quite effective medication, loperamide, which a number of people will have taken when they've been away on holidays and had problems with diarrhea, and it really does slow the diarrhea down effectively. But we have a number of other interventions for sickness, for pain, for diarrhea, intravenous fluids. So all of these things are given rapidly to try and minimize the impact of this mucositis. If you're in as an inpatient, which most people are, of course, by then when they're suffering from these side effects, you tell your doctors what's happening, and there should be a low threshold for really just giving medication to minimize the effect. Fluids are so useful. Intravenous fluids make people feel so much better, because there is a period of maybe 5 to 7 days where these bowel side effects are the worst. And it's all about trying to get over these days with the minimal amount of difficulty, because it can be, very unpleasant. And I think it's important that we do highlight that.
It's very common. And I think Katie spoke about this on one of our previous podcasts, for people to go off their food. It's unsurprising. If you're feeling queasy and you've got the runs, you're not going to want to eat a 3-course meal. Not that the NHS necessarily provides that, ice cream or otherwise. This induction period with myeloma can be interesting, because you can gain weight with the steroids during initial treatment. That's pretty common. And then you can often lose some weight during the transplant period. So there is a degree of balance there. But of course, the teams looking after you during your transplant still need to keep an eye on that, even though actually some patients might quite like to shed a few pounds. We don't want that to tip too far, because you need to keep up with your nutrition as much as possible. And so whilst the diarrhea and maybe feeling sick might be going on, and you may be off your food, you may still be asked, for example, to see a dietitian and consider some additional supplements just to keep things a bit more in balance, because otherwise you can feel pretty grotty if you're not eating for a couple of days, despite having fluids and all those other supportive medications.
It's very unusual that we need to support nutrition in a more aggressive way. Occasionally, there is this approach where you put in what we call an NG tube, where a tube goes from the nose into the stomach and food is given that way. For this sort of transplant, I have to say we use it extremely rarely. Nutrition is so important, but if you go a couple of days and you can't eat much, I generally tell people it's okay. Don't stress yourself out thinking, I need to eat, I need to get nutrition in, because it is difficult. I think on those days, really have a bit of what you feel like. The appetite and the ability to eat does come back relatively quickly.
So something else which is incredibly important during this process, as well as the diarrhea and the nutrition aspects, is infection. And actually that's where it's so important that we've done those tests to look at your heart and your lungs and such like beforehand, because if you pick up an infection, which is incredibly common during this period, and just to remind our listeners, this is much more likely because the melphalan has removed temporarily those cells which enable us to fight infection. And so there is that inherent vulnerability to infection during this period. And therefore, infections are very common. And so if you were to pick up an infection through no fault of your own, often the infections come from within your own body, actually, the bugs that exist within your own body, then we need to get on top of it quickly. And you need to receive antibiotics quickly and fluids quickly and all the tests and investigations that go with an infection to make sure that we calm it down promptly, because otherwise, as I'm sure our listeners can imagine, if those cells aren't quite there in the body to fight an infection, infections can become quite nasty, and that can happen relatively rapidly. So every hospital that does transplants is very familiar of the risk of infection and the importance of giving the right antibiotics at the right time to minimise the effect. But that is a relatively common problem to be expected. When it occurs, it can feel pretty unpleasant, but hopefully equally is treated quite promptly.
Everyone gets an infection. I think in Oxford we do about 50 to 80 transplants a year, depending on the year. There may be 1 or 2 people that do not get an infection, but it's incredibly rare. And it can be everything from, honestly, what just feels like a simple fever that you didn't even notice, to difficult infections that can be life-threatening. Now, part of the reason why they can be so severe is really going back to what the chemotherapy does to the bowel, and it takes away the lining of the bowel before new lining grows back. And that means bugs that are normally kept in the bowel, which can cause serious infection, are able to get into the blood and cause serious infection. So time is of the essence, Sally, as you mentioned. Like, as soon as there are markers of infection, which is usually a fever, but it can be a bit more vague than that, antibiotics are started immediately. The risk of infection really starts to pick up around day, what we call +5-ish. And it's very much linked to when some cells called the neutrophils, so these are the white cells that are particularly important in fighting bacterial infection, go down. And what people tend to like when they're on the transplant is knowing what's happening with their blood counts, right, Sally? Because especially the neutrophils, because they go down and go away completely. And that's also an indicator for the doctors and the nursing teams. It's like, right, we're at peak risk time now. But then there's that very satisfying flicker initially, and then the movement of those neutrophils going back up again, which is indicating that the stem cells are back home and they are working, and people are getting, hopefully, towards the end of their admission into hospital.
Yeah, absolutely. And it's really interesting that time, even if you didn't have your blood results to refer to. What I'm sure it's the same for you, Jem, with all the, many patients I've looked after going through this transplant. They tend to say, I just feel a bit better today. I don't know why, I just do. And then you look at their blood results, you say, oh, look, the platelet counts come up a bit. And oh, look, it's a flicker of neutrophil recovery. And then, you're out of the woods, you're on the up, and it's just a matter of waiting and days. And often infections can persist until that neutrophil recovery. And so it's when the neutrophils have come up that you can then think about changing the antibiotics, weaning them down and stopping them. So it's quite normal to be on antibiotics for 5 days, 7 days. But that those infections tend to burn out towards the end of that time because the neutrophils come back and help the body do what it needs to do.
Yeah, as my old mentor, who you also know, Sally, Tony Goldstone, one of the first consultants I ever had, he'd say the best antibiotic are your neutrophils.
Yeah.
And he's spot on. You start to see those coming back and you know that things broadly are going to get better. So that is certainly a reassuring sign. As we did say, and we should talk about this at this point, Sally, sometimes people unfortunately get really sick and it's normally an infection that is hard to control. But a number of patients, probably around 5 to 10% of people, will have to go to intensive care. And I mean, what does that mean, Sally, and why do we have to do that?
It's really important when you're consented for your transplant. I'm sure the medical teams will go over this with you. But going to intensive care is another way of more aggressively supporting your body to be able to withstand, more often than not in this context, an infective process. And sometimes a nasty infection can really impact on your blood pressure, for example. And that's obviously, you need good blood pressure to pump blood around your body. Otherwise, your organs start to struggle. So sometimes people go to intensive care to support their blood pressure. Sometimes if you've got a really nasty infection in your lungs, you might not be able to get enough oxygen into the body via the lungs, and so they might need some breathing support, or the kidneys might struggle. So there are lots of ways in which intensive care can support those particular parts of the body or the organs of the body that are struggling. Often it's due to an infection. And again, as the neutrophils pick up, what you hope to see when somebody is in intensive care is that need for that extra specialist support decreases, and then people can come off intensive care and then recover further on the ward.
Thank you. And our intensive care colleagues are fantastic, and they really understand hematology. They understand that as the neutrophils start to come back, what they are doing hopefully will just be for a short period of time before recovery. Unfortunately, and it still happens, a small proportion of people don't recover. This is the hardest thing to talk about when you are consenting, or when I'm consenting someone for a transplant. I don't know what you feel, Sally, but you have to say, there is a chance of dying, there is a chance of not recovering, normally because of an infection, and that risk is extremely small. And we say it's about sort of 2% of all autologous stem cell transplants done. Now, the difficulty, of course, with that is that for the person, it's absolute. It either happens or it doesn't happen. But what I'd say is most of the time, it's not even close to happening. But it's important that we mention it.
Yeah, I definitely agree. And one of the reasons it's important to mention it is that transplants remain a key part of our pathway, but they're not the only part of the pathway. And so if someone is particularly concerned about a transplant, or the doctors think actually it might be a bit too risky to proceed with the transplant because the heart's not quite as healthy as it need it to be, or the kidneys or whatever, you don't have to have a transplant. And so I think it's a case of figuring out the risk and the potential gain of going forward for the transplant in the event of something like that, which is obviously catastrophic, happening. But it's also really important to say that with any treatment, that risk is there. Having myeloma is a condition that you need to take seriously. So it's not like transplant is the only risky thing we do. And I think it's therefore very important to place it in that sort of context as well.
So for most people, it will be admission on the ward the first week or so. People may be more outpatient based. On average, we tell people they'll stay in for sort of 3 to 4 weeks. The vast majority of people get antibiotics and will have some mucositis, bowel-related symptoms. Other things to consider, because, of course, we take away the effect of the bone marrow to do its job properly before those stem cells kick in. The cells that produce platelets often get sluggish. It's quite common to require platelet transfusions, and you may require red cell transfusions as well, but actually that is much less common. And that's because the mature red cells that are in your blood are not affected by the melphalan, and they live for many weeks. I mean, they live for about 90 days.
Yeah, definitely. That may well be necessary. Although, I think there is increasingly a trend to, particularly in terms of platelet transfusions, and moving away from that. I think there was a study done a few years ago showing that they're less essential than we originally thought. So some people may not need that at all. And then we've forgotten something which is incredibly important, particularly for our patients, which is hair loss, which tends to happen to near enough everybody. Often prior to going into the transplant, people might go and see a wig specialist, a shawl to go over their head if they don't want to have a wig. And they tend to notice that their hair start losing their hair a couple of days perhaps after the melphalan's gone in. They just notice it in the shower, it comes out more loosely. And then sometimes people actually, and we've both seen this, I'm sure, just say, actually, enough of this. Enough of bits and bobs falling out. I'm just going to shave all my hair off. And then once they're out of the transplants and they're recovering at home, they see it grow back. And so that, again, is a temporary side effect, but it takes a little longer for obvious reasons for your hair to grow back.
Yeah, but it does grow back. We can't guarantee what colour it will come back as. Certainly it has been different in some people. But again, it is a temporary side effect, but clearly a very significant one that affects people's appearance. So we're getting towards discharge. So people have got through the side effects, the blood counts have come back up. And often your team will say you're ready to go home when they are comfortable that there is no infection, normally that you've been off antibiotics for a couple of days, or they're happy for you to go on tablet antibiotics and your blood counts are safe, because the last thing we want to do is send people home too early and then they're back again a couple of days later with a fever or a problem, which is still directly linked to the transplant.
It's quite easy to underestimate, actually, the impact this can have on the body. I think people, particularly in the hospital, because they felt perhaps sometimes so terrible having this diarrhoea and infections such like, when that does pick up, there can be an optimism, like, oh God, I feel really good again. I feel great. Let's get home. But I think always a word of caution, because this does knock the stuffing out of you, literally. And so when you get home, even though you might feel stronger in hospital, people very frequently feel quite fatigued. They've been through an awful lot, and exhaustion can be a problem. Regaining the weight and their appetite and the tummy settling down can also take a number of weeks, if not longer. And so I tend to say, give it at least a couple of months, maybe 2 to 3 months before you really feel like you're back to who you normally are. Some people get there more quickly, but definitely go easy on yourself. Give it time. Don't book lots of things in a diary. Don't book holidays. Don't book parties. Just one step at a time. And sometimes people struggle to see that improvement day to day. But if they look back week by week, it's easy to say, actually, last week I was struggling to walk around the garden and now I can do that easily. Now I can go out for a longer walk with my dog, for example. So it's a case of being patient, taking it easy and gently, and knowing that you will eventually get there.
And people really do. And as you say, I think they notice, well, last week I could do this, but this week is much better. There may be a number of visits initially to the hospital, so more than you're used to, because we'll need to check that your blood counts are still going in the right way. You may need the odd transfusion. There'll be certain antibiotics that you go home on to stop you getting infections in that period. And actually, some minor level bowel type symptoms may persist for quite a while. Just the feeling that you can't quite eat what you want to, your bowels might not be completely back to normal, but it does all return to normal. In the vast majority of people, the blood count completely returns to normal too.
Your lines. So this can be quite a big deal as well. We spoke about the importance of having what we call access or good veins during our stem cell collection podcast. But this is also incredibly important during the transplant side of things, because you've got to make sure that those cells go into the body nice and easily. But also if you need lots of fluids or blood transfusions, that they can also be given easily. For those patients, when they come into hospital for the transplant, often prior to admission or on the day of admission, a line is put into their body. Access is secured. Now, more often than not, this is a line that sits in the upper arm, something called a PICC line, which is like a really long cannula that allows access to the circulation. So you can take blood tests every day, which we need to do. You can give things into that line every day. And it just saves all the hassle, really, of endless needles. These lines tend to be very well tolerated. However, there are some complications that could go with them, which are not infrequent, which include blood clots. And so sometimes people get a little clot on the line and they need to go onto blood thinners, or infections, because theoretically this is a route an infection can get into the body. And so occasionally people have to have these lines taken out halfway through their transplant if they think they could be infected. But more often than not, they're an absolute gift. They save a lot of stress and pressure, and as soon they're placed in the body when someone is admitted, and they tend to be removed when you leave hospital.
They have hugely improved the experience of a transplant. You can take blood through them. A lot of them, you can put the stem cells through them. Now, in some places, the stem cells are still given through a separate cannula, but lots of PICCs, you can safely give stem cells through them. Antibiotics, fluids, medication. So the number of needles that you have during the transplant has gone down very significantly. And that really does improve the experience. You can shower with them. You can walk around easily. When you need to take them out, you just pull them out. They sort of sit in the top upper arm. And often they are put in the day before the melphalan. So people will have the PICC line, and then the next day they'll have the melphalan, and the day after that they will have the stem cells. Certainly in our patients, Sally, I don't know what happens down where you work in Bristol, we 99% of the time always take out the line before people go home because they just don't need them afterwards.
You don't want anything hanging around your body reminding you of your hospital stay if you don't need it. And then something else really important to say about this. So you think you've got this sort of line dangling from your arm. It can be a real problem, or people are very concerned about washing and showering with these lines in as well. Now that, when you're in hospital, imagine if you've got a runny tummy and you're not feeling great, you want to clean yourself. You can do that, but you do have to be careful that you don't get the line or the dressing soggy. So it's just something else to think about. And that's another reason for taking them out actually when they are discharged, so someone can just feel a little bit more like their normal self.
So that's it, guys. Autologous stem cell transplantation in a pod. So we've collected and frozen your stem cells. Then for a few weeks, we will check your organs, check you're fit to proceed, and then you'll get the go-ahead. So you'll have a PICC line put in. The day after that, you'll have your melphalan and, of course, your ice lollies. And the day after that, in the vast majority of people, you have your stem cells infused, and don't forget the sweetcorn smell. Now, for the first few days, you may be an outpatient or what we call ambulatory, because symptoms really start to kick in around 4 to 5 days after the cells. Then the things to watch out for are all those bowel side effects that we talked about. Diarrhea can be very prominent, and of course the risk of infection, which in the majority of people we treat on the ward and we rapidly get antibiotics in. The blood count and the neutrophil count, specifically that white cell, goes away completely and then starts to come up slowly, and then we know that people are on the upward trend then. Blood counts recover, people come off antibiotics, their appetite returns, the diarrhea improves, and then you're ready to go home. After you go home, it will take some time, but you will get back to normal. And in a nutshell, that's your stem cell transplant.
Please get in touch, everyone out there, and share your experiences with us about what a transplant's been like for you. Because, some people sail through, some people have a rough time. So this isn't one size fits all, but that is a brilliant overview of what to expect.
As you said at the beginning, over the next couple of weeks, we're going to build in layers into this. We're going to have a pod with one of our transplant nurses where we'll really go over a lot of this again in a slightly different way. And then, of course, get the patient voices on. And we will have people who've had slightly different experiences because, as you say, Sally, it is different for people in lots of different ways. Thank you all very much for listening, and we'll see you all at the next one.
Take care.
Bye. This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.